Thank you, Dr. Meena. Good evening to all of you, respected Professor Bagasar, Professor Aditi Sinha, today's speaker, Dr. Jiten Meena, and case scenario presentation shall be done by Dr. Bhavati Dipti. Now I request Professor Bagasar to introduce the Dr. Jiten Meena and so that thereafter he can start the lecture and question answer session. Professor Bagasar.
Thank you, Dr. Mishra.
Yeah.
And it's great to have this talk by Jitendra, who is a alumnus of the All India Institute. He did his MBBS, MD, and then DM in pediatric nephrology from this institute. And he'll be talking to us on a very important topic of acute glomerulonephritis. This diagnosis is relatively common diagnosis, and if you are working in wherever you're working, this would be a diagnosis that is often made. The diagnosis is not very difficult. I think the differential diagnosis is difficult. What are the likely causes that can cause acute glomerulonephritis? And because we often think, that the chief cause and perhaps the only cause is post-strep GN. That's not really the case. And so Jitendra will perhaps be going through the differential diagnosis today because the differential diagnosis determines the outcome. So Jitendra, can you begin? Thank you very much for taking this talk.
Thank you, sir, for this kind introduction. So I would be covering over next 20 to 25 minutes overall approach to acute glomerulonephritis and pediatric population. So this is the overview of my talk. So to begin with, acute glomerulonephritis is chiefly inflammation of glomeruli. Clinically, it's characterized by a combination of symptoms which would include hematuria, chiefly the glomerular hematuria, oligonuria, proteinuria, edema, and hypertension. So the key would be, to diagnosis the glomerular hematuria in presence of edema and hypertension. The pathological correlate of this process is inflammation and cellular proliferation within the glomerular complex. One of the key manifestation is to look at the urine analysis and demonstrating the dysmorphic RBCs or acanthocytes in the urine, and then obviously one would also look at the blood pressure and the protein as well. In clinical practice, especially for at postgraduate and fellows level, one should be very clear about where to denote nephrotic syndrome versus nephritic syndrome. So few of the key things which would be able to help us in differentiating between nephritic presentation versus nephrotic syndrome presentation. Nephrotics are usually insidious onset, while nephritic syndrome is acute onset. Edema is more of pitting in nephrotic state, while in nephritic syndrome is non-pitting edema. One of the key manifestation which will help in differentiating is oligonuria. So in nephrotic syndrome, typically you should not have a drop in urine output, while is one of the key manifestation of nephritic syndrome. Another thing which is crucial is presence of RBC or hematuria in nephritic stage. So in the typical nephrotic syndrome, you should not have RBC cast or dysmorphic RBCs. A small proportion might have few RBCs, microscopic hematuria and nephrotic syndrome, but in nephritic state is one of the key manifestation which would provide the initial diagnosis of acute glomerulonephritis. For kidney dysfunction, it should not be there in nephrotic syndrome, but in most of the patient with acute GN presentation, you would found some or large rise in serum creatinine. Hypoalbuminemia is typically a feature of nephrotic syndrome, but can be there in nephritic syndrome if there is nephrotic range proteinuria. So coming to the approach of patient with acute GN, so most of these patients would either have history of cola-colored urine, or sometimes parents might describe it as a smoky-colored urine. There would be decrease in urine output, facial puffiness, or even pedal edema might be there. Then simultaneously, one should also evaluate the etiology of underlying GN. So if you have like upper respiratory tract involvement like cough or sinusitis might point to the granulomatous polyangiitis as underlying cause of acute GN. So you should also look at the lower respiratory tract involvement, so that you should also ask history about skin rash, palpable purpura, abdominal cramp, bloody diarrhea, which might be indicator of underlying disease as a IgA vasculitis. Then one would also look at the rheumatological clinical symptoms like joint swelling, stiffness, oral ulcers, pointing towards the SLE. Then simultaneously, one would also look at the complication feature like over evidence of fluid overload in terms of dyspnea and shortness of breath, headache, visual disturbance, or encephalopathy might suggest that there is severe hypertension. In examination, one need to chiefly focus on assessing for blood pressure, hypertension. Tachycardia and tachypnea might be there because of hypertension or fluid overload. Then upper respiratory tract involvement should also be evaluated. So does one also look at the skin rash, palpable purpura, and oral ulcer. Rest of systemic examination is chiefly to look for complication related to fluid overload, or there might be hepatosplenomegaly if you have suspected underlying cause as a lupus nephritis. So once we evaluate clinically, then next step, to look for the laboratory investigation. And one of the key investigation which help in establishing the diagnosis of acute GN is the urine analysis. So in urine analysis in acute GN setting, one would find the dysmorphic RBCs, RBC cast, and WBC cast, and proteinuria. So if you have these, then this is very much a confirmatory diagnosis of acute GN. Then one would also look at the complete blood count to look for hemoglobin drop, or there may be thrombocytopenia, and in peripheral smear one should look for evidence of hemolysis, because your hemolytic uremic syndrome can very well mimic the acute GN setting, and even presence of cytopenia might provide a clue that the underlying cause might be the SLE. Then to assess the severity of kidney dysfunction, one would want to look at the serum creatinine, and urea and serum electrolyte are chiefly to look at complications associated with kidney dysfunction. Complement C3 level is one of the crucial essential investigation what would help you in deciding the underlying etiology. I would be dealing with in next few slides that how does complement levels help us in the deciding the underlying etiology of acute GN. The next few investigation would depend, the overall what would you find in the initial clinical evaluation and the first line investigation. So if you think that this might be on the PIGN, then one would want to look at the ASO titers and anti-DNA B titers. If you think that the cause might be vasculitis or SLE, then one would order further ANA, anti-DSDN, and ANCA. So other further investigation were chiefly determined by initial investigation and clinical evaluation. So as I said that glomerulonephritis is basically inflammation of glomeruli and is chiefly triggered by the immune complex formation. So you might have immune complex antigen antibody being circulated in system, and they get deposited in and trapped in the glomeruli. So these immune complex can be get deposited in the subendothelial surface, or maybe subepithelial surface. So subepithelial space is basically between the endothelium and your epithelial cells, while subendothelial is between glomerular capillaries and your basement membrane. So another way that you have antigen already being there in the glomerular basement membrane, and antibodies are from outside and they get entrapped, and antigen immune complex are formed in situ within the kidney parenchyma. And if these antigens are of origin of glomerular antigen, then you can have disease something like membranous nephropathy. So these are the way where inflammation can start within the glomeruli. So overall approach to acute GN patient, once you have glomerular hematuria, which we chiefly determine based on evidence of dysmorphic RBCs, RBC cost, and evidence of proteinuria inside with edema and or hypertension. So you would evaluate that whether there is preceding history of infection. You would look at the urine analysis, the serum C3, CBC, and blood urea and creatinine. So in peripheral, if you find evidence of thrombotic microangiopathy, which is characterized by hemolytic anemia, thrombocytopenia, then you would think in terms of HUS, and the SLE can very well mimic the diagnosis of TMA. And there is evidence of ongoing infection. This is chiefly hospitalized patient and critically sick patients. So then one would want to think about Staphylococcus associated GN. As I told you that C3 is one of the crucial investigation which would help us in determining the further etiology. So if you have low C3, there is evidence of preceding infection, then is likely to be post-infectious GN, or more commonly known as post-Streptococcus GN. If there is no preceding evidence of infection, then one would think of C3 glomerulopathy. And patient with lupus nephritis, again, you would have low C3. Normal C3 presentation of acute GN would may happen in patient with IgA nephropathy, IgA vasculitis, or ANCA-associated vasculitis affecting the glomeruli and leading to glomerulonephritis. So in today's talk, we chiefly covering the overall, infection-related GN, as the rest of the etiology would be covered in next few webinars. So IRGN is the umbrella term which is used for a patient who have GN either with the preceding evidence of infection. So there is some latency following infection. So you have post-infectious GN. Then there can be ongoing infection. So it's an infectious GN, which is chiefly the Staphylococcus associated GN. So in the patient with post-infectious GN, you would usually have preceding evidence of infection with either bacteria, virus, or some other organism, which is leading to immune complex formation from antigen antibody, and they get deposited in the glomerular basement membrane and mesangium, and ultimately leading to inflammation and glomerulonephritis. So post-infectious GN, or chiefly the post-Streptococcus GN, is the most common form of glomerulonephritis seen in pediatric population. However, with better improvement in the socioeconomic strata and availability of antibiotics, the overall incidence been declining trend, and is Western world, especially in developed world, is not a major problem. But in the developing world, like countries like us, and low and middle countries, it still remain a major problem, and overall incidence is almost 4 to 5 times in our part of world compared to Western world. So for us, it's remain an important disease. So it's chiefly a problem of school-going children. So typical age of presentation is, would be 3 to 15 years of age. You have history of either sore throat, pharyngitis, or skin infection, and is followed by some latent period depending on the underlying preceding infection from 2 to 4 weeks. Then you would develop the clinical evidence of acute GN. So there are specific strains of Streptococcus pyogenes which associate with sore throat and the pyoderma. The overall incidence following pyoderma is higher compared to the sore throat. However, the epidemiology of the post-Streptococcus GN, there is some data which suggests that it's been evolving and changing. So one of the crucial things that now compared to before 17 and 80s, now is more commonly implicated with the pharyngitis compared to the pyoderma. And now there seems to be more gross hematuria compared to previously where you had more hypertension and edema. So a typical course of PIGN would be reflected in this figure. So you have group A streptococcal infection, followed by there is some latency. So during this latency only, so this blue line reflect the complement C3 level. So during this latency period only, there is a beginning of the declining the serum C3 level, and it would spontaneously resolve by most of the patient by 10 to 12 weeks. So following this infection, there is a rise in the ASO titer. So this ASO titer is typically at peak at from 6 to 8 weeks. So depending on what stage the patient is coming to you, you might in fact get low titers, like if you do within 1 week, or if you do it beyond 10 to 12 weeks. So it's always recommended that you should not base your diagnosis based on single ASO titer. One should show the rising titer. So at least 2 ASO titers should be done, specifically in our part of world where you can have false positive ASO titer. So another important manifestation, which is hematuria. So hematuria usually begin after 2 weeks of latency period, and in most of the patient it would subside by 7 to by 3 to 4 weeks. And the first initial manifestation will be resolved, denoted by this black line, is hypertension and edema. So in most of the patient, within 2 weeks, your hypertension and edema should be improved. If you look at the overall frequency of the symptoms, any form of hematuria is probably the most common manifestation of PSGN. Then you have hypertension and edema, and almost 60 to 90% patient would have depletion of serum C3 levels. So PHGN or PSGN diagnosis is chiefly clinical. So all patients, we don't do biopsy to diagnose a patient with PSGN and PIGN, because it's typically diagnosed based on your typical clinical presentation. But there might be atypicality in presentation, and those patients we would need biopsy. So if you have rapidly progressive form of glomerulonephritis, which is characterized by rapid deterioration of kidney function over days to weeks, and chiefly characterized by oligoinuria, gross hematuria, and severe hypertension. Or you have nephrotic stage, that means that you have nephrotic range proteinuria, and there would be edema. Or if your urine output is not improving, or if you have persistent of severe AKI beyond 10 days, because in a typical patient with PSGN, it should have been resolved by 2 weeks. Or if you have persistent of gross hematuria beyond 2 to 3 weeks, if there is normal complement levels, or you have extrarenal manifestation like joint pain, arthralgia, palpable rash, which are suggestive of that underlying cause of acute GN might be non-PSGN. During recovery phase or follow-up period, if you have persistent of nephrotic range proteinuria beyond 2 to 3 weeks, or C3 level is still low beyond 3 months, or there is persistent of proteinuria UPOC of more than 5 milligram per milligram beyond 6 months, or there is persistent of microscopic hematuria beyond 18 months. So these are, some rough estimate or clue to which would help us that there is ongoing disease activity, and one should look at the kidney biopsy. So depending on the stage which we are doing kidney biopsy, they are histological picture can change. So if you do biopsy early on, this would typically show the glomerular endocapillary proliferation with maybe some focal or segmental glomerulosclerosis. In the typical phase, the biopsy picture would show the diffuse global proliferation. And if you do biopsy very late, then there might be some mesangial proliferation there. Immunofluorescence chiefly show the deposition of C3 and IgG. The patterns may be starry sky and other form of patterns. So these are the light microscopic variation which can be there in the patient with PSGN. So this first picture is typically showing the diffuse neutrophilic exudation full of neutrophils and inflammatory cells. Then rarely in the PSGN patient you might have crescent. So crescentic presentation is also reported with PSGN. So this is showing the proliferation and kind of patient. Then if you do biopsy later or beyond 4 to 6 or maybe 6 to 8 weeks, you might have a picture suggestive of membranous proliferative GN. In the immunofluorescence, either you see the deposition of IgG and C3 along the glomerular basement membrane. So this is your garland pattern. And along the glomerular basement membrane, you can also see, mesangial deposition of C3 and IgG. So this is typically known as starry sky pattern. The classical description of electron microscopic picture of PSGN patient is the subepithelial hump deposition. So this is subepithelial space where you have this dense deposits in the electron microscope. So coming to the management of patient with the acute GN, so initial management would be supportive. So patient should be monitored for urine output, blood pressure, and kidney function. Patient who have severe edema or hypertension would require initially salt and fluid restriction. Those with significant edema, which is roughly defined by weight gain of more than 5 to 7%, severe AK and stage 2 should be hospitalized and managed in hospital at least for initial few days. The initial choice for managing patient with severe edema and hypertension would be furosemide, because in the patient with acute GN, the chiefly cause of hypertension is salt and fluid restriction. So furosemide therapy should be used. If you have stage 2 hypertension or severe hypertension, then calcium channel blocker like amlodipine can be used initially. Coming to the treatment in form of immunosuppression. So hardly there is any data to support the immunosuppression evidence in the patient with the post streptococcus GN. So overall, our approach for immunosuppression in the acute GN or PIGN patient is that when kidney biopsy is indicated, you should perform it. Kidney biopsy is showing the crescentic GN, so that almost 20 to 20 more than 25% of glomeruli are showing the crescents on biopsy. That is defined as crescentic GN, which is a surrogate of rapidly progressive GN. So these patients we would manage with IV methylprednisolone pulse 3 to 6 pulses and intravenous cyclophosphamide 6 doses, 4 weekly 6 doses, followed by tapering dose of oral steroid and either azathioprine or MMF for almost total duration of maybe 1.5 to 2 years. So there, crescentic GN, that's how we manage. But if you have patient with RPGN presentation and showing the diffuse proliferation on the biopsy, there we would definitely use IV methylprednisolone for 3 to 5 doses. While there is no data to support that whether endoxan cyclophosphamide to be used or not, but we would be more aggressive in patients with diffuse proliferative GN, and most of the time we would end up giving either oral or IV cyclophosphamide with total duration of immunosuppression varying from 8 to 12 months. So there would always be doubts and controversies around antibiotic therapy in the patient who have post-streptococcus GN. So overall, to summarize, overall data, if there is acute streptococcal infection, then you should treat it with antibiotics. Symptomatic family members you may consider, but you may not achieve great advantage with that. In setting of epidemic or outbreak of streptococcal sore throat infection, there is a data to support that prophylactic antibiotic may help in reducing the overall incidence of PSGN. Coming to the overall long-term outcome is excellent in the patient with the post-streptococcal GN, on which less than 1% would have chronic kidney disease. So one of these studies of long-term follow-up data of 15 to 18 years, so that almost 3 to 5% patient would have evidence of hypertension of microscopic hematuria. So overall, excellent is very good. The factors where one need to be careful in terms of long-term follow-up, that if you have severe AKI at presentation, crescentic glomerulonephritis on kidney biopsy, or nephrotic state at presentation. So these are the factors which would predict the long-term poor outcome. So these patients would require long-term follow-up. So coming to second form of infection-related GN, that is Staphylococcus-associated GN. So this is chiefly suspected in the patient who are hospitalized and have ongoing infection. So apart from Staphylococcus-associated GN, other infections which can present as a ongoing infection and GN are Staph epidermis, Klebsiella bacteremia, and E. coli. So mind you that Staphylococcus-associated GN is a chiefly disease of adults. It's rarely reported in pediatric population, and there are some specific risk factors like IV drug user, diabetes mellitus, where you might have deep-seated infection. So there one would need to be aware about that Staphylococcus-associated GN. The typical presentation of SAGN is the severe AKI, microscopic hematuria. Nephrotic range proteinuria is much more common here compared to the PIGN patient. Almost 20 to 30% patient would have leukocytoclastic vasculitis, which is also seen in patient with IgA vasculitis or anaxylin purpura. Typical presentation SAGN patient, that most of them would have severe AKI and RPGN presentation, and kidney biopsy would chiefly show the mesangial proliferative GN and deposition of. Apart from C3, the IgA deposition is also described, and some researchers would also name this disease as a IgA dominant infection-related GN. So a light microscopy picture can vary from mesangial hypercellularity to endocapillary proliferation, but a considerable proportion of these patients might have necrotizing crescentic or crescentic glomerulonephritis. So in adult literature, the diagnosis of SAGN is suspected when you have culture-proven Staphylococcus infection, and there is acute proliferative GN with, apart from C3 deposition, you also have IgA deposition. The additional systemic features or laboratory investigation which can be seen in patient with SAGN are leukocytoclastic vasculitis. Almost 20 to 25% of these patients may have ANCA serology being positive. So treatment is chiefly to control the underlying infection. So one should not embark directly on the immunosuppression, looking at the histological evidence and sometimes crescentic GN. So here the chief treatment is to use long antibiotic and control the underlying infection. And rarely you might need to use oral steroid despite controlling the infection, and patient is infection-free if you have persistent of the kidney dysfunction. So the key differences between PIGN, post-streptococcus GN, and Staphylococcus-associated GN, that the later one is while ongoing infection in form of deep-seated infection, osteomyelitis, septic arthritis. The PSGN usually have preceding infection. The clinical picture here is chiefly typical of acute GN. In SAGN, most of the time you have nephrotic range proteinuria and severe AKI. Outcome of Staphylococcus-associated GN is definitely poorer than PSGN patient, where you almost have progression to CKD in almost 1/3 of the patients, despite appropriate management. Coming to the two last entity, which is typically described with IRGS patient, are infective endocarditis. So the chief organism which are implicated in these are Streptococcus mutans, and rarely gram-negative bacilli. The typical presentation is of acute nephritic syndrome. Then rarely as a systemic manifestation you have anemia because of chronic ongoing inflammation. There might be splenomegaly and purpuric rest. Again, management here is to control the infective endocarditis rather than directly embarking on the immunosuppression. So immunosuppression is always better avoided, despite being necrotizing vasculitis evidence in the histology or crescentic GN. One more entity similar to this is shunt nephritis, which is chiefly seen in patient. We have ventricular atrial shunts. So these shunts are rarely performed nowadays. We mostly have ventricular peritoneal shunt. So risk of shunt nephritis with this is very less. The bacterial organisms which are implicated are Staph epidermis, Staph aureus, and Pseudomonas. Again, presentation, apart from nephritic picture, you may have anemia, hepatosplenomegaly, and skin rash. Again, the therapy is chiefly intravenous antibiotic and controlling the underlying infection. If you remove the shunt, and so overall prognosis is good here compared to infective endocarditis. So to summarize, the post-streptococcus GN still remain a good, important disease for us, and especially in pediatric population. And most of the patient is self-limiting, but one should also be aware that where we should think about other form of underlying etiology of acute GN rather than PS, just focusing on PSGN. Role of immunosuppression, while in crescentic GN setting is clear, but for other form of histology is controversial because there is limited evidence to support that. But when you have some doubt or there is ongoing fever that there is might be ongoing infection, one should carefully look for the underlying ongoing deep-seated abscess or infection if you have atypical presentation. SHGN is more of a disease of the adult population, but is now being with more aware. It's being increasingly reported in pediatrics as well. So controlling infection in patient with SHGN and infective endocarditis is the key treatment rather than focusing on immunosuppression. So thank you everyone for your patient listening. I've completed my talk. Thank you. Hello.
Yes, sir. Good evening. Yeah. May I request Professor Bagga for his comments and Dr. Mishra, sir?
Thank you, Jitendra, for an excellent talk. I think very well designed and a very well presented talk, and highlighting the ways you would diagnose and how you will evaluate these patients, keeping all the differential diagnoses in mind. So we'll now move on to Dr. Deepti, and she'll be talking to us about certain cases and perhaps emphasizing what Jitendra has just mentioned. Deepti.
Thank you, sir. So, respected faculty, my dear colleagues and students. So, I'm Dr. Babiti Deepti, Assistant Professor at Department of Pediatrics, DIPMA. And after that excellent talk by Dr. Jitendra, we will try to understand this entity better with some case scenarios. And please continue asking your questions. I will receive some interesting questions in the chat box. So, coming to the case scenario number 1, we had a 7-year-old boy who presented to us with history of cola-colored urine, decreased urine output, and periorbital edema for a period of 3 days. He had no history of joint pain, skin rash, or oral ulcers. This was to rule out the extrarenal manifestations. There was no history of headache, vomiting, seizures, or altered sensorium. Also, there was no history of any breathlessness on exertion or orthopnea. Past history revealed history of multiple pyodermas on the lower limbs 3 weeks back. So on examination, we could appreciate some healed pyodermal scars over his lower limbs. On examination and anthropometry, he weighed 22.4 kg and height was 120 centimeter, which was normal for his age. Vitals revealed a heart rate of 92 per minute, respiratory rate of 22 per minute, a blood pressure of 118/75, which was more than 95th centile for his age. So he had some hypertension. There was periorbital puffiness on general examination, and we could appreciate healed pyodermal scars over both lower limbs. Systemic examination on respiratory system was normal with bilateral air entry equal. There was no murmur. Per abdomen showed no evidence of any ascites or any genital edema. Central nervous system examination was also normal. As Dr. Jitendra said, in such scenarios where there was cola-colored urine with some edema and hypertension, suspected could be acute glomerulonephritis, we would go ahead with some essential investigations. The urine analysis. Urine analysis was performed in this case, and we saw dysmorphic RBCs, RBC CAS, and some albuminuria. The urine protein, spot urine protein by creatinine ratio was 0.5. The kidney function test, the urea was normal, 28, with a creat of 0.5, which came to an estimated GFR of 99 ml per minute per 1.73 meter square. The serum albumin of 3.2 mg per deciliter. Complete blood count was sent along with peripheral smear. Hemoglobin was 11.7, total leukocyte count of 7,100, and platelet count was also within normal limits. The next step, serum complement levels were sent, and it was found to be low, which was 36 mg per deciliter. The normal in this units would be 80 to 156. ASO titer was found to be high. Yes, this was only one titer, but as he said, we should be sending serial titers to look for evidence of any streptococcal infection. Anti-DNase B was also found to be positive. So what probable diagnosis would you like to think here? I think the diagnosis is quite clear. So we'll just approach the way Dr. Jitendra has told us. So suspected acute glomerulonephritis. We have glomerular hematuria in the form of cola-colored urine. We confirmed it by urine analysis. There is some mild edema, not to the extent of severe edema, and there was definitely hypertension. So one would suspect acute glomerulonephritis here. Now we need to look at, we need to rule out some extrarenal manifestations. We asked questions about joint pains. We asked about skin rashes, purpura. On examination also, it was not there. There was some history of definite preceding infection in terms of pyoderma, but there was no ongoing infections. The investigations also ruled out cytopenias. So this arm would go out. We sent a serum C3 level for this child, and we found that it was low. So we would proceed in that algorithm, and with the history of a definite preceding infection, I think the diagnosis of post-infectious glomerulonephritis is quite clear in this case. Now the question is, which organism could have caused the infection? Usually streptococcal infections are considered to be the prototypical infection of PIGN in more than 95% of cases, as in this case. However, other bacteria and viruses are also implicated. In this particular case, pyoderma, presence of ASO positivity and DNase A positivity pointed towards PSGN. We went ahead with supportive management. Hypertension was managed with furosemide and later with amlodipine. During the course of this child, edema had subsided by day 3, hypertension subsided by day 7 with supportive management alone. And at 8 weeks follow-up, when repeat C3 levels were sent, it were found to be normalized. So this is just a revision of what we have already listened in the theory class. That is, post-streptococcal is usually the prototypical PIGN. It has a distinct infection-free period, like in this case, we had 3 weeks. And as highlighted in the previous talk, these are the different manifestations. Usually there'll be a preceding infection, pharyngitis or pyoderma. And most commonly, we see the gross or microscopic hematuria. 80% cases can have edema. Hypertension is also noted, and majority of them have low C3 levels. It is a self-limiting disease. It improves within 1 to 2 weeks of disease onset. Fluid restriction and salt restriction usually suffices. We sometimes go ahead using calcium channel blockers as antihypertensives. ACE inhibitors are to be avoided in acute glomerulonephritis because they can worsen the hyperkalemia and also worsen the renal function. The timeline, similar, as you have already seen this timeline, there was an infection, then there was a latent period of 3 weeks. The hypertension and edema, as you can see in this black line, was there, and it subsided by around 3 weeks. The ASO titers also, you can see serially it goes on increasing. The green line here refers to hematuria, and as we can see in this, the hematuria is the last symptom to disappear. So microscopic hematuria can persist for quite some time. The complement levels are also initially low, and they normalize by themselves within 8 to 12 weeks. This transient hypocomplementemia, which is seen in PIGN, is virtually diagnostic of PSGN. So by 8 to 12 weeks, when we get a C3 level repeated, it is usually normal. If it persists to be low, then it is concerning and we need to think of other diagnosis. So this was a case of classical PIGN. Now moving on to case scenario 2. a 9-year-old girl child presented with periorbital edema and pedal edema for 7 days, cola-colored urine and oliguria for 4 days, breathlessness on exertion and orthopnea for 1 day, history of pharyngitis 1 week back. On examination, we found that heart rate was 120 per minute. She had some tachycardia, respiratory rate of 28 per minute. Tachypnea was there. Blood pressure was in stage 2 hypertension, more than 95 plus 12 mmHg. Respiratory system examination revealed bilateral diffuse crepitations, and there was tender hepatomegaly. So this case, urine. Then we went ahead with the urine analysis, which showed dysmorphic RBCs and RBC CAS with the presence of some subnephrotic range proteinuria. And as you can see here, there was elevated urea, 196 mg per deciliter, and a creat of 5.2 mg per deciliter. Serum C3 levels were sent, which were low, that is 23 mg per deciliter. And since the clinical examination was suggesting probable fluid overload and pulmonary edema, the chest X-ray was performed. That was also showing the bilateral diffuse infiltrate suggestive of a pulmonary edema. So what is the diagnosis here and how is it different from the previous case? Previous case also came with a short history, acute onset hematuria, there was some edema, but then what is striking here is that the child here has presented with some complications of fluid overload, and the hypertension is also quite high. The RFTs are also quite deranged. So what is the diagnosis here? Again, we'll go through the same algorithm. We have ruled out other things. We sent a C3 levels, it was low, and it could probably be PIGN, but what is striking here is the deranged KFT and a rapidly progressive course. So somebody in the chat box had asked whether PIGN can present as an RPGN. Yes, PIGN is known to present as RPGN, but usually the numbers are low. Only 15 to 20% have AKI, and more so the crescentic GN is seen in 3 to 5% of cases, but they can present as RPGN. So is kidney biopsy indicated here? I think by now you would be knowing, because Dr. Jitendra had highlighted what are the indications of biopsy in a PIGN, which is otherwise a self-limiting disease. So this is one of the indications we just saw. A rapidly progressive course. Any case where you're suspecting RPGN, somebody has presented you with deranged KFTs, has come to you with pulmonary edema, severe hypertension, throwing seizures, having press. So that is one definite indication of doing a biopsy in PIGN. Or gross hematuria or oliguria persisting for more than 10 days, depressed EGFR for more than 2 weeks, normal complement levels at admission, and extrarenal manifestations. At late stages, if there is persistent nephrotic range proteinuria for more than 2 to 3 weeks, we said that complement levels would normalize by 8 to 12 weeks. But if they persist to be low, yes, we have to go ahead with kidney biopsy. Also, microscopic hematuria is the last symptom to resolve. But if there is persistent microscopic hematuria more than 18 months, it becomes an indication for biopsy in PIGN. So these are some indications we would like our residents to remember. So in this case also, we went ahead with a kidney biopsy, and the light microscopy showed 26 glomeruli, 17 of which showed cellular crescents, and there was a diffuse exudative proliferation pattern. Here, the small arrow in my slide shows a crescent. As you can appreciate here, it is in the crescent form, and the crescent here is seen to be compressing the tuft of glomerulus. You can appreciate a diffuse increase in the endothelial cells and mesangial cells, and there is some, the capillary loops also have some neutrophils and leukocytes. So this is a diffuse exudative proliferative pattern classically seen in PIGN. On immunofluorescence, there were 11 glomeruli, of which IgG and C3 were equally positive, 3+. And the picture here demonstrates that you can see the yellow arrow here shows that you can appreciate that C3 deposits are showing a lumpy, bumpy, coarse granular staining in the capillary loops and the mesangium. We can have a garland variant or a starry sky appearance on IF in PIGN. This is a representative image of how a PIGN would look. So classical subepithelial humps are seen. This is a basement membrane, and this is the subepithelial area. You can appreciate the subepithelial humps here. This is just to show you, this is a subepithelial hump, basement membrane, and if there were deposits here, it would be subendothelial deposits. So the Diagnosis in our second case is crescentic glomerulonephritis or RPGN due to PSGN. The clinical course of our index child was the child continued to have uncontrolled hypertension for few weeks. The child was on 3 antihypertensives. Child required 6 sessions of hemodialysis over next 2 weeks. The treatment-wise, as Dr. Jitendra highlighted, immunosuppression in PIGN is very controversial and lacks evidence. However, when we do a kidney biopsy and when we have diagnosed that the child is having crescentic GN, we would like to go ahead with IV methylprednisolone and IVCP, IV cyclophosphamide 6 pulses monthly over each month, followed by maintenance with MMF or azathioprine and tapering dose of steroids for a duration of 12 to 18 months, which was done for the current case. When there are no crescents, IV methylprednisolone is given to arrest the inflammation. Plus minus IV or oral cyclophosphamide can be used with tapering doses of oral steroids for a duration of 6 to 12 months. On follow-up, by the end of 3 months, the creatinine in this case had decreased to 0.56. UPUC was 0.1 at the end of 3 months, and the child was off antihypertensives by 3 months. So as you might notice in this case, although this case presented with RPGN, ultimately the outcome seems to be good. That is what happens. The AKI requiring dialysis of crescentic GN due to PSGN is rare, 3 to 5%, but usually the prognosis is excellent even in crescentic GN due to PSGN. And the progression to CKD is very rare, less than 1%, and ESKD is even extremely rare in these cases. Coming to our case scenario number 3. We had an 8-year-old boy with high-grade fever and pain in right hypochondrium for last 7 days. On examination, the anthropometry was normal. On a per abdomen, there was tender hepatomegaly with the enlarged liver span. The complete blood count showed a hemoglobin of 12.1, and there was some leukocytosis with TL's neutrophilic leukocytosis. The liver function tests were normal. Ultrasound abdomen was done for this child, and there were multiple hypoechoic areas in liver, the largest measuring 4.6 into 6.6 into 5.9 centimeter. So here, this is a case presenting with liver abscess. So we have a 8-year-old boy here presenting with liver abscess. So the abscess was drained, a pigtail catheter was inserted, and the pus cultures were sent, which grew MRSA. Now, during the course of hospital, you would realize that 3 days later, we realized the child had started to develop oliguria. There was some worsening periorbital edema, pedal edema, scrotal and ascites, scrotal edema and ascites. Stage 2 hypertension was also noted in this child. Urine analysis showed that there were 418 RBCs, with majority were dysmorphic. There was a nephrotic range proteinuria, and there was a deranged creatinine of 1.8 with eGFR of 32 ml per minute per 1.73 meter square. So what is your diagnosis here? I cannot see any answers in chat box, but this is the second case scenario which Dr. Jitendra was talking about, where there's an ongoing infection, and later the child presents to you with some features of nephritis. So classically, in severe acute kidney injury, in the presence of nephrotic range proteinuria, hypertension, and glomerulonephritis with an ongoing infection, you would suspect a. Here it was, since we have the diagnosis that it was an MRSA, this is a classical case of staph-associated IRGN. Such scenarios are usually rare in pediatric age groups, most commonly seen in adults, but this is one case that we encountered. So IRGN, I will just re-emphasize what has already been told. Infectious related glomerulonephritis could be associated either with an ongoing infection or following a latent period. The first 2 case scenarios that we discussed were following a latent period. The first one presented with mild manifestations. It was self-limiting, received no treatment. The second case that we discussed was also following an infection with a latent period. However, it had some deranged KFTs. It was a crescentic PIG and required immunosuppression. This is the third scenario which we saw here, that is Staphylococcus associated glomerulonephritis. So how did we manage this case? For the liver abscess or the active infection, we gave antibiotic therapy, that is intravenous vancomycin, with necessary dose modifications as per eGFR. Fluid and salt restriction was done, which alone led to weight loss of 4 kgs over the next 2 to 3 weeks. hypertension had resolved, proteinuria had resolved, and there was the child improved with antibiotic therapy alone and did not merit any immunosuppression. Usually, in the presence of active infection, immunosuppression is not given. So this is the same table which has already been shown to you. So how is a PIGN different from a staph-associated glomerulonephritis? What we see most commonly as pediatricians is a PIGN case, which occurs after an infection, streptococcal infection. A majority of them after a pyoderma, in some cases pharyngitis, while staph-associated infection is usually in concomitantly with the infection. Simultaneously, infection will be going on and there's no latent period there. But it is less common in pediatric age group. It is seen after infections like skin infections. It could be a liver abscess, some deep-seated abscess, and endocarditis, etc. The presentation is similar. Both have cola-colored urine. They can have acute onset edema. However, the degree of AKI is more in staph-associated IRGN, and the nephrotic range proteinuria is also more in staph-associated glomerulonephritis. Low C3 levels are classic here, while it can be seen in 30 to 50% of staph. ANCA positivity is also seen in subset. As we said previously also, PIGN usually has complete recovery and an excellent prognosis. However, staph-associated GN prognosis is unpredictable, and especially if crescents are there, it can be a bad prognosis. Briefly telling you about the differences on light microscopy in both these scenarios. A diffuse exudative glomerulonephritis, diffuse increase in the endothelial cells, mesangial cells, and the neutrophilic exudation into the capillary loops is seen in PIGN. IRGN or the staph-associated IRGN, ATN is more common. Interstitial inflammation is also more common. In PSGN, somebody was asking about Garland and starry sky pattern. So this is a classical Garland pattern where heavy C3 deposits can be seen all along the capillary walls. While in starry sky pattern, they are diffusely distributed and there are C3 deposits. These Garland patterns usually have more heavy proteinuria compared to the starry sky pattern PSGNs. In IRGN, what is striking is the presence of IgA deposits along with IgG and C3 deposits. So it is also called IgA dominant glomerulonephritis. PSGN, as we discussed, there are large subepithelial humps are more characteristic, while more mesangial and subendothelial deposits may be seen in IRGN. Subepithelial humps are also described in 31% cases of staph-associated IRGN. So now the last case scenario, we had a 10-year-old female with rashes over bilateral lower limbs, painful swelling of right knee and bilateral ankles for 3 days, along with history of periorbital edema and cola-colored urine for 1 day. On examination, as you can see here, this is a photograph taken after 2-3 days, but initially they were palpable purpura, more so in the dependent areas. The right knee, right and left ankle joint were swollen and they were warm and tender. There was hypertension, as you can see in this case. Coming to the workup of this case. So this case scenario I have put here just to highlight the fact that the history that we take will decide the etiology of the child. This is also acute in onset. This also has cola-colored urine, edema. But what is striking here is that the presence of these extrarenal manifestations, which will make us think of diagnosis other than a PSGN. This is where we would like to think of other differential diagnosis. We could think of a IgA vasculitis here. We could think of a lupus nephritis here. So the workup wise, hemoglobin was normal, the total leukocyte count was normal, and platelet was also normal. So cytopenias were not there. The C3 levels were also normal, 82. The renal function tests were, in this case, was 22 and 0.4 creatinine. Urine microscopy showed 46 RBCs in the presence of 1+ albuminuria. Urine protein by creatinine ratio was 0.8. Skin biopsy was sent, which was suggestive of leukocytoclastic vasculitis, and IgA deposits were present. So this is what we were saying, that in such scenarios where you have extrarenal manifestations, think of etiology other than PSGN. I will not go into the further details of what the diagnosis was in this case, but for you, it is we need to remember that when there are normal complement levels at admission or presence of extrarenal manifestation, it becomes a indication for diagnosis and to look for other differentials than PSGN. Take-home messages. Acute nephritic syndrome is commonly due to PSGN or PIGN in India. Staphylococcus-associated glomerulonephritis or the IgA dominant IRGN is acute nephritic syndrome, which occurs concomitant with staphylococcal infection and more commonly seen in adults. PSGN is usually self-limiting, so perform kidney biopsy only when it is indicated. Load of immunosuppression is controversial and limited evidence. Crescentric PIGN, however, immunosuppression has to be given. Actively look for the evidence of infection wherever there's an atypical presentation with IRGN. Thank you.
Thank you, Dr. Dipti, for all the four cases scenario presentation, especially the first one, classical, which we see more commonly. Then unusual presentation, maybe in 3 to 5% of the cases, RPGN. And the third one and fourth one is relatively rare. Third one is another presentation. So we can see someone has asked, okay, is there any difference in the outcome between garland pattern and a starry sky pattern in kidney biopsy? Dr. Dipti? Yeah, Dr. Meena?
The garland pattern is known to present more commonly with more degree of proteinuria.
Yeah.
But as such, there is no,
as such, there
evidence
is
to
no-
support that one pattern would have worse outcome compared to the other one.
Yes, only the degree of proteinuria would vary in these cases.
Another question is that whether in case scenario for the diagnosis was HSP or something else.
So which case last case, sir?
Case 4.
Yes, sir.
Where you showed the arthritis and skin lesions.
Yes, that case was a case of IgA vasculitis or HSP nephritis only. And as we can see in the lab workup also, the platelet count was normal. There was leukocytoclastic vasculitis and IgA deposits were present. Next question was, should we do kidney biopsy? Yes, we have to do kidney biopsy in this case and confirm our diagnosis. I've not elaborated further in this case scenario because it will be discussed in further.
There is a clear-cut message if there is extra-renal manifestation, especially the joint involvement, this one, skin manifestations, both sometimes skin biopsy is done, but in such scenario, kidney biopsy is essential to find out the degree of involvement and further immunosuppression.
Yes, sir.
Yeah. I think both of you have answered most of the question. Professor Bagga, sir, your comment, please. One more question is, how common is fungal, protozoal, or viral associated nephritis?
It is quite rare only.
Yeah.
As I mentioned, more than 95% is usually streptococcus. Even Yes.
Someone has asked, what is the next hypertensive BP is not controlled by calcium channel blocker?
So usually we would avoid using ACE inhibitors in the acute GN setting, as already been described that it may lead to hyperkalemia.
Hyperkalemia is such nephrotoxic also.
And so if one is BP is not controlled with CCB, then one can try, the either prazosin or maybe, beta blockers.
Yeah, that is the usual practice. Wherever there is a AGN, oligoinuria, azotemia, we avoid ACE inhibitor and ARB both because they are nephrotoxic below. If they normally they have EGFR less than 30, and as such they have to be avoided, and they can lead to fatal hyperkalemia as well. Let me see the questions. I think.
Bagga sir, any comments?
Yeah.
Kendra, I think both you and Deepti have done a great job. Very nice presentations, and absolutely in synchrony. Each one emphasizing the highlights of the other page of the case. So clearly, it's so the management continues to be supportive, and but one should keep the possibilities of non post-strep GN always in mind. Yeah, one should just not, don't wait, because the biggest concern at times is the RPG patients with RPGN, who are often, kind of nothing actively. Because I think the first 1 or 2 weeks is crucial, for diagnosing. In fact, there are very few emergencies in nephrology, and RPGN is one of them. So you need to diagnose early, because once you get RPGN, then you end up getting crescents that are fibrocellular or fibrous, and that's a problem. So I think one has to have a reasonable index of suspicion when you're managing these patients. But overall, very, very nice presentations. Thank you.
Really excellent presentation by both the speakers. Dr. Jitendra, thank you very much, Dr. Jiten and Dr. Dipti. And Dr. Jiten has been very active in last 1 year. He has started the postgraduate quiz program for in field of pediatric nephrology and the NEfPRO with ample supports of Professor Bagga sir, Professor Hari and Dr. Sinha and our President Dr. Susan and members of executive and academic committee. With these few remarks, I hand over the platform to Dr. Jiten to carry out post-session this one question answer session mainly in the form through the link. Now you will have 10 questions, MCQs.
No.
Yeah.
Dr. Deepthi, please stop sharing this slide. Sweta, you need to start the post webinar.
Yes, sir. Shall I start, sir?
Yeah.
Okay, sir. Fifteen seconds. 5 seconds more. 15 seconds. 5 seconds more. 20 seconds left. 10 seconds left. 20 seconds more. 5 seconds more. 15 seconds more. 5 seconds more. 20 seconds more. 5 seconds more. 15 seconds more. 5 seconds. 15 seconds more. 5 seconds. 20 seconds more. 10 seconds more. 20 seconds more. 5 seconds more. 'So we are done with the poll, sir.
Okay, thank you, Dr. Sneha. Dr. Jiten?
Thank you, Shweta.
Thank you, sir.
So our next webinar on the series would be on rapidly progressive glomerulonephritis. So as you know, already described by Bhaga sir, this is one of the key emergencies we see in pediatric nephrology. So that webinar would be crucial. So
Dr.
with that,
Jiten? Yeah,
yes, sir.
Dr. Jiten, on next turn, I would be in a journey.
Okay,
I
sir.
have to go somewhere else. So I request you and Professor Bhaga sir to conduct the session.
Okay,
And
sir.
thereafter, I am available. No problem.
Okay, sir. No issue.
Okay. That is on 19th. But 26th, I will be there. Okay.
Sure, sir. No
One
issue.
day. Okay.
Okay.
So thank you very much for today's presentation to you and Dr. Dipti as well. And excellent platform and excellent. This is a very common topic, and every postgraduate residents, fellow, and young faculty should know very well in detail clinical presentation and investigations and management outcome. So with these few remarks, I hand over to you to go ahead with the stoppage of this session. Thank you, Dr. Jitan. Thank you.
So thank you everyone for joining us, again today. So we'll hope that you'll be joining on next Friday as well. With that, I'll conclude this as today's session.
Thank you, everyone, for
Thank you.
sharing their valuable insights. We are more than grateful to everyone present here. We have hope to have you again on our platform soon. Thank you, everyone.
Okay, thank
Good
you.
night.
Good night.
Good night.
Good night to all of you.
Thank you, everyone.